I really much enjoy doing this topic for many reasons, but I do want to give you a bit of warning. This presentation is going to be potentially basic because we have to cover so much in such little time. I do list some resources at the end that I will not go over, but might give you some direction as well based on previous feedback. And hopefully that will be also helpful and different from last year. And we always look for feedback. So after the presentations, please let us know what you might want to change, what you might different, because we do look at that and I do try to adjust. And different groups have different kind of composition, so people might want different things to focus on. So I will expect some potential disappointment because it's not going to cover everything that people want. And I will hopefully expect some places of growth and things we could change for next year. So without further delay, I'm going to do my disclosures and tell you a bit about any bias and everything else, and then we'll proceed with the material. So money. So I have to disclose to you financial relationships. I don't have any grants or research support at this time. I have done speaking for Takeda and Sanovian. Takeda is the one that makes 5-ins. I do have a separate company, Triumph, the consulting fees. I have no patents. I wish I was that smart. I get paid through OHIP and I get paid through Alberta Health when I do locum in Alberta. I also do some work with Ontario Medical Association. I also teach through the CAOT, which is the Canadian Association of OTs. So I do courses through them and I get paid. I do independent medical assessments as well, where I see a lot of ADHD. And I have done some physician coaching. So that's kind of my other sources of income and bias. So in terms of acknowledgement for the financial support for the program received financial support from Ministry of Health and Long-Term Care in the form of an annual funding agreement. The program received some in-kind support from CAMH and Unity Health in the form of clinician time and logistical support. And again, potential conflict of interest disclosure. I have not received any funding or payment from an organization supporting this program or organization whose products are discussed in the program. So I do not get paid for any of this. The information presented in this CME program is based on recent information and it is evidence-based. So every time I prepare for any topic, I do my updated research, and particularly with ADHD, I always update myself on a weekly basis. So this is evidence-based. In terms of a disclaimer, we're not providing any treatment, medical, personal, or legal advice for individual patients or situations. This is kind of general case, general learning. The education and the information is educational in general. So again, this is not particular patient or particular case, right? You kind of take the information and you apply it within your license, your hospital expectations, your workplace expectations. This is introductory level because of the time constraints. And if you are experiencing mental health distress because of this presentation, please see your own physician or your healthcare provider or emergency department. And the reason I put it there is because sometimes when we talk about certain things, people identify either their own experience or their family's experience, or, they kind of come to realization about their life or potentially their own diagnosis, and it becomes very triggering. So please, acknowledge your emotional distress and get the help that you might need. And I will apologize. I do speak fast, especially because I'm on a time clock because I want to make sure we have time for questions. So I will be speaking a bit faster. So the learning objectives for today is, what is ADHD, right? People throw around ADHD. What is it? Number 2 is, how do we actually diagnose ADHD? And number 3 is, okay, what are some special considerations? And this literally changes year to year because things from last year are a bit more things we have to consider this year. So there's a lot more material every year. The time is the same, the material gets bigger. So what is ADHD? There's a lot of misunderstanding about what ADHD is and what it isn't. In the past, up to 2013, even where it was in the diagnostic and the DSM-5, which is the DSM-5-TR, which is the kind of diagnostic guide we have today in 2024, but prior to 2023, we had different version. And again, ADHD used to be in a section for behavioral issues and kind of conduct issues, whereas it moved into a section for neurodevelopmental conditions. And neurodevelopmental condition means that somebody's born with it, right? It's something that's there since birth. And the criteria that DSM-5-TR defines, this is the criteria that we use right now for diagnosis. And the criteria is persistent pattern of inattention and or hyperactivity, right? So inattention, there is 6 symptoms for 6 months or longer. That is not what you would expect to somebody's developmental level. And there is impairment on social, academic, or occupational domain, right? When you talk about hyperactivity and impulsivity, again, it's 6+ symptoms for 6 months or longer. That again is not congruent to where they should be developmentally, and there is impairment. Now, when we're looking at any diagnosis in psychiatry, we have to make sure that it's not because of another medical condition, that it's not because somebody has active head injury or recent head injury, or, some other reason that could look like ADHD. The other thing is, as I mentioned, because it is now neurodevelopmental condition, there has to be some symptoms present prior to age 12. So, with ADHD, people don't just wake up at age 30 and all of a sudden it starts. There would be some symptoms in childhood. Doesn't mean they were diagnosed, because they might have not had resources, their family might have not wanted to pursue the diagnosis, they might have not been recognized. And so there's many, many reasons why people don't get diagnosed in childhood or picked up, but there's usually some history of it before. And there has to be at least 2 or more domains of function impairment. So, people have to struggle with something. And there's 3 types. There is the combined, where people have inattention and hyperactivity, mostly inattentive or mostly hyperactive impulsive. And, sometimes people say in partial remission, that it might not satisfy all the criteria. Okay. I'm good for next slide, Olivia. Thank you for... Oh, sorry, I think we skipped on. All right. So how common is ADHD? And I know we were just chatting about how, it's all over TikTok, it's all over social media, and that kind of becomes very confusing for people. Well, statistically, there's about 2.5% prevalence in adults. Now, is that accurate? I don't know, because there's many adults that we haven't diagnosed, so that statistic might change. When I was looking at the CADEC information, which is the Canadian organization, they estimate about 1.5 million Canadians probably have ADHD, right? So that's a lot of people with ADHD. Usually, the earliest we will see symptoms are usually 3, 4, that's when we could potentially diagnose. Now, there is no specific cause of ADHD. Like, we can't say, well, it's this is what caused it. Today in 2024, in August 2024, we do not have a specific cause of what causes it. There's risk factors, so potentially low birth weight, prematurity, if the prenatal smoking exposure, if there's any other neurotoxin exposure, infections, and intrauterine alcohol exposure, right? Those are risk factors. It is extremely heritable condition, 74% from parent to a child, okay? So often you will notice the pattern of parents getting diagnosed after their child was diagnosed, or even grandparents realizing ADHD after their grandchild was diagnosed, or sibling, or, parent, or somebody else. So it is important to kind of recognize that a lot of the times people are seeking diagnosis these days is because there's much more knowledge, but also because when their children are diagnosed and they're being assessed, they often identify those symptoms from their own childhood, or the pediatrician suggests that one of the parents or both parents get assessed, or again, siblings, and people have more conversation about it. There is no particular test or biological marker. It's not like I can give you a blood requisition or scan your head or do anything. So again, in August 2024, there's no specific test or biological marker is going to say, yes, you have ADHD. Okay, so that's very important to know for our clients, our patients, and for our own knowledge. So the one thing also too is if you might see families, if you're a family doctor, if you're a social worker, you might see a family and multiple family members might have ADHD. ADHD can look very different across family members of the same family, the genders, and even lifetime, right? You might have one sibling who's hyperactive, one sibling who's inattentive, and this is where sometimes siblings are missed because one sibling has such severe hyperactive symptoms that all the attention is on that sibling, and the shy, quiet, and attentive sister is missed because she's not causing problems, she's not getting sent or getting kicked out of school. So it's actually quite common for a lot of siblings who do not have as clear hyperactive impulsive symptoms to be missed by the family or by whoever else is treating them. And often again, there's both partners in a couple might have ADHD as well. And so they all present differently. And sometimes it causes frustration because people say, well, they can't have ADHD, they're not like me. But again, it's like saying depression. You could have both partners have depression. You could have different family members have depression, and they could look different when they present depressed. So ADHD can be different even in the same family. And ADHD presentation could be very different because of so many different factors. Again, you could have a sister and a brother, two brothers, you could have the same family, and they could have a very different level of function, severity, impairment, and there's so many things that influence that. Okay. So there's a bit of an issue sometimes with, how we diagnose ADHD based on the DSM-5 criteria. The criteria changes every few years, and even the fact that it got moved into neurodevelopmental section, was a big change. In the past, there was also exclusion. You couldn't diagnose ADHD and autism in the same person. We know that there's a huge, huge co-occurrence or comorbidity between the two. So that exclusion was removed, right? So you have people now presenting with both because they've always had both. We just didn't recognize it. So there's limitations to our current diagnosis. And the current diagnosis, when you look at the DSM guide, it doesn't actually include emotional dysregulation as a symptom. Emotional dysregulation is a tendency for emotions to change very quick, have big emotions, big outbursts, quick to have an emotional reaction, right? So as kids, they're often described like volcanoes or temper or emotional and reactive. And as adults, they continue to do that. And, at the current way of diagnosing ADHD, it doesn't really capture adult domains of impairment as well, because again, and we're so used to looking at how they do at school, how are they keeping up at schoolwork, that when we look at adults, we forget that the adult domains that require executive function include driving, finances, household management, relationship management, management of their healthcare appointments and coming to your appointments, doing what you expect them to do for their treatment, right? Doing taxes, schooling, employment, managing their own children if they have any. So those are the adult domains that are often missed if we just look strictly at the criteria. And currently, if we actually look, again, about 50% of adults meet ADHD criteria in partial remission, and 15% continue to meet the full criteria by the age of 25. Because again, people used to think that you used to grow out at 18, and that's still, unfortunately a myth that persists there. This is not a Cinderella story. It doesn't disappear the moment at midnight you turn 18. Like, this is there for you, all your life. And so this is why you will have people now who, are in their 60s and 70s and 80s questioning if they've had ADHD all their life when they have their grandkids and their kids getting diagnosed. And this is why we have this developing area of ADHD in geriatric population, because we don't really know what to do. But once we're realizing that, hey, this is actually a lifetime condition, it is a lifetime condition, ADHD persists. And, the other thing with what we used to have to do is people used to, the kids used to have psychoeducational and neuropsychological testing. And it's nice. It's very nice, because then you could identify learning disorders, processing disorders, and all the other stuff, reading, difficulties and learning disorders. But the problem is, first of all, it's very inaccessible. It's very expensive. Some of the wait lists through schools are like 2-3 years. Can't really get it in adults. And the problem is that it actually can miss ADHD as well when you interpret it, because it's not necessarily specific. So ADHD is still a clinical diagnosis. We have to look at what's the clinical picture and the clinical assessment. And the way I suggest to people is to look at the lifetime model, right? Look at the lifetime progression of the impairment, the symptoms. And we have to understand that with ADHD, most of the time the hyperactive symptoms become less prominent in adults. They might not be as hyperactive, or it's internalized, so you might not see it as much. But the inattentive symptoms persist, and inattentive symptoms is what cause the most impairment. It's not the hyperactive symptom that's going to cause a car accident. It's the inattentive symptom, because you got distracted, you missed the red light, you missed the stop sign, you got distracted, right? That's what's going to cause a car accident. That's what's going to cause a workplace accident, not the hyperactive symptoms. So the inattentive symptoms are the most missed, and they're the most impairing, and they persist the most into adulthood. Okay. So this is just an example of how it might look across different life stages. And again, you see how I put adulthood. I didn't really cut it off at 65, because again, we need to consider that adulthood, we need to consider what happens past 65. And we're not really considering that because we don't have as much information on how to differentiate cognitive disorders like dementia versus longstanding ADHD. And that's a big clinical conundrum sometimes that I can't even answer. So these are kind of just, giving you an idea about how people might look across a lifetime. Next. So why are we sometimes seeing more ADHD in adults? Why are you seeing people showing up in your office? Aside from increased awareness on social media. So the way I approach that is that, look, in the past, if you wanted to get awareness about a medical condition, you would have a physician expert go on some kind of a talk show, go on, TV, do an interview, publish an article somewhere, be a guest writer in some kind of magazine that everybody was reading, right? You'd go on Opera, you'd go on whatever, you'd go on CP24 in Toronto, you'd have a section, you'd talk about stroke, you'd talk about things, right? And those experts would be selected by the TV station would approach you, or the editors would approach you. It would be very focused, very selected on what things wanted to do. With social media, the platform has gone to the patients because now anybody can go up there and talk about their experience. So it expanded how the information is shared. So it allows for a lot more lived experience. And lived experience is valid to people who experience it. It's not expert opinion, right? It's not evidence-based. There's no regulation. There's no professional bodies regulating it. And so, there is a good thing that there's more awareness and people are talking about it, people sharing experiences, people can relate, and people can start thinking about it. At the same time, there's no vetting the information. There's no kind of professional obligation to actually, disclose anything else besides what they think is ADHD. So when people come to me and say, listen, I saw this on TikTok, and remember on TikTok or any social media, the moment you click on one video, it kind of brings up the algorithm that then all you see is ADHD. So it kind of becomes biased, right? And I think it's good that people bring it into our office and talk about it, because it's no different that if somebody saw something about stroke on TV or something about any other medical condition and said, hey, can we talk about it? And then it's for us, physicians, clinicians, caseworkers to say, okay, let's look at the facts. Let's look at the information. Let's look at the evidence. Let's look at what it looks like. And it's for us, it's our job as trained professionals who are, supposed to use evidence-based or who's supposed to use information carefully. It's for us to figure out, is this actually ADHD? So I don't get frustrated when people come in and say, hey, I think I have ADHD. I say, let's talk about it. Let's look at the information. And then we figure out what it is. And so the reason, so there's social media, there's more kids being diagnosed and more recognized, the teachers are more recognized, and then the parents are being suggested to be assessed. And then in terms of the environmental demands, we need to understand is that as you go through life, our demands, executive function and everything increases across the lifetime. As we transition, especially aged 18 to 25, we transition into adulthood, huge demands we're facing. And at the same time, most of us lose scaffolding. For example, going to the doctor's office, we don't expect the mother of 20-year-olds to call to book an appointment to remind them of an appointment. We expect the 20-year-old patient. But if that 20-year-old patient has ADHD, they're going to forget and miss the appointment, right? And if mom says, okay, well, you take care of your own appointments now, they're lost scaffolding to remind them about appointments, right? Now you have to pay taxes, you have to register paperwork, you have to maintain a job. There's so much more that happens 18 to 25. And especially if the individual moves away for schooling or leaves home, there's so much more expectations and loss of scaffolding that they usually have from their school, from family, from the community, from any other supports that they have. And even in particular, if you think about that, programs for type 1 diabetes, the pediatric programs are very involved and very supportive, but at age 18, they have to transition into adult programs and they lose so much more support and they start struggling with managing type 1 diabetes, when they're 18 onwards. And managing type 1 diabetes is very intense because you really have to be constantly monitoring your sugars, constantly, monitoring insulin and, figuring out how you feel. So that becomes a big issue often for people with ADHD and diabetes or other chronic conditions when they lose that medical scaffolding magically at age 18 because we now consider them adults. So these are things we have to consider. And points of transition in jobs, life roles, such as parenthood, moving from an employee to a manager, becoming a case manager to now becoming the manager. It leads to a lot of overwhelm because there's a lot of cognitive demand, anxiety, overcompensation, depressive symptoms, low self-esteem, and sense of failure. Because the moment we change cognitive and functional demand, how much things you have to do, change in whatever structure they got used to, and change in supports, and if we add any more distraction to it, think like parenthood, right? Tons of distractions, tons of new things to remember, change in your structure because you don't have a structure now. Your baby can wake up at any time. Becomes really overwhelming. And they often will present to us at that point after a certain transition happened voluntarily, like having a child, or involuntarily, like they graduated, they moved out, they moved into a house, they had to switch jobs. So transition points are key when people will struggle and present to us, or when we could support them and scaffold them, especially if you know that there is one coming up. Next. Okay, and so this is, again, just an example I'm giving you about the domains. As you could see, when you go from, I didn't include the early childhood, but as you could see, elementary school to transition 1825 and adulthood just keeps getting bigger. And we don't remember that all of these things are actually affected by ADHD. And over here, I mean online behavior and sexual behavior. That's a huge domain that we have not addressed. Sexual behavior, meaning impulsive sexual behavior that could put somebody at risk, or things that could be seen as a legal offense, including touching somebody at work, tapping somebody on the shoulder, tapping somebody on the back. That could be seen as sexual harassment, right? But with impulsivity, people will touch, people will make comments. And at age 18 to 25, that has legal consequences. You could be kicked out of school, you could be kicked out of work, because it's now seen as sexual harassment, right? Online behavior, people can make comments that can create bullying, that can cause all sorts of consequences, including legal consequences. And so again, all of this executive function to remember what to do. Health management is a huge one. Remembering your appointments, remembering your medications. Age 18 onwards, people are responsible for their own healthcare, right? So that becomes a huge one. Finance is a huge one, right? Because that's a opportunity to get credit cards, accumulate debt, impulsive spending, staying on task with bills, taxes, huge. Potentially parenting. Traveling is a big one. Traveling is a huge executive demand function. You have to plan. You can't lose your passport. You have to make your flights. You have to, there's a lot of stuff that you have to do. And household management, getting your groceries, taking out the garbage, doing your dishes, doing your laundry, right? All of these things that we take for granted are actually things that become an additional task if you don't have mom around or family around to remind you and do all of this. So this is why I kind of highlighted. So coming back to the next slide. So this is emotional impulsivity. And again, emotional impulsivity or dysregulation is a huge unrecognized symptom of ADHD, and it contributes to so much impairments in occupation, education, criminal, and driving outcomes. So I always ask people, road rage. And a lot of my patients from Toronto said, no way, I'll get shot, right? But, when I ask people in other places, they don't have the same deterrent. So that is one thing I always look for: road rage, speeding, reckless driving, tickets, and things like that. And occupational, right? If people are having outbursts, yelling, screaming, telling off their boss, they're going to lose their job. And again, like, emotional regulation is a core executive function that we have to do. And it is prevalent throughout lifetime. And it is hugely affected in parenting because parents often get overwhelmed, they get dysregulated, they have an outburst, and we judge them as, angry parent, right? When they're actually dysregulated. Next. Okay. So objective number 2, how do we diagnose? Again, it's a clinical diagnosis. It requires talking to the patient, collecting history, and getting the symptoms and understanding the patient. You don't need to have a neuropsychological testing or psychoeducational testing. This is the expert consensus, and this is the CADRA guidelines. I often will have that written when there's forms, like university accommodation forms, because they shouldn't be asking for this. It's a clinical diagnosis. It's not required to have testing. It's a clinical diagnosis by talking to the clinician. Next. So this is CADRA guidelines. They're fantastic. They're Canadian. They're free. Anybody can access them. They provide a nice package to guide you how to help you. Again, it's free. It's there. And they kind of divide it into 4 steps. Information gathering. That's where you try to get history, starting with developmental history, because remember, it's prior to age 12. You're looking at childhood, you're looking at, different stages of life, and don't just focus on academics. It's not what grades they got and what they graduated. It's how did you manage to get the grades? How were you in school? If I was to observe you, what would the teacher say about you, doing schoolwork? How did you complete it? And the collateral if possible, because, there's many people that you can't get collateral. For example, when I see patients who are refugees, I won't be able to get collateral from the teachers, the report cards. They were in a refugee camp. They might not have family. There's many parents who refused to have this diagnosed because of stigma when the people were kids. So they're going to deny because they don't want the diagnosis. They might feel shame, their failure as a parent. So many times I might not have collateral. And so what I will do is I will see if there is a spouse who can provide one or a partner. Sometimes there's a sibling, and sometimes their workplace feedback or their university performance or other, how they perform. And I will ask, so, in your swimming club or at your work, what are some of the issues, or how do people describe you, or what happens at work? And I will get collateral indirectly through that. But many times people come in for assessment because of workplace issues, and we will use that review or assessment as part of collateral. Number 2 is always medical review. You want to make sure there's no other medical conditions that one either could mimic or look like ADHD, or could be a thing that we have to further assess, particularly if there's any heart issues, high blood pressure, any, head injury, anything that might be something that we will have to assess further before medication prescription, or that is really important to consider. And again, in the CADRA package, they do list several questionnaires that are done by the patient or that are free. I think Diva, you have to pay, but it's a very good diagnostic interview for ADHD. And so these are the questionnaires that you could use. And then you could bring the patient back for feedback and treatment review. So it doesn't have to be a one-time appointment, right? And usually you do want to get developmental history, and you want to look at functional impairment. So it's not just, I can't pay attention. It's, well, what are the adult or, what are the other domains that are affected? Because just because one can't pay attention, are they actually impaired? Because, to have a diagnosis, you have to have an impairment. Next. Okay, so these are other questionnaires that would be very helpful. And again, there's so much comorbidity between ADHD and substance use, particularly cannabis. And sometimes people say, well, I can't assess ADHD, they're smoking pot. You know what? Unfortunately, cannabis is the most commonly abused substance. And because it's legal, many times you'll get history now. People are starting to use pot since they were like 7, 8, 9, 10, because their parents might give it, or, it's there. So worse, Wender-Uter rating scale helps with kind of differentiating into symptoms way early on, ideally before they started cannabis. And you can even do that even by history, prior to starting cannabis. What was your concentration? What was your, cannabis isn't going to change the procrastination when they were 8, unless, they started cannabis before. So those are things that you kind of can look back prior to cannabis use. And I always ask what led them to cannabis use in the first place. And often they say, I can't shut my mind's too busy, I can't sleep, because sleep is another commonly missed symptom of ADHD. That is a core issue in ADHD is people can't sleep. They have this chronic insomnia, busy mind, restlessness. So these are some of the other things way around cannabis and ADHD. Next. Okay, so these are common things to consider. And again, I mentioned you don't need the neuropsychological testing. Often people say, well, is it ADHD or is it trauma or is it this? Comorbidity is the rule, not an exception. I get actually very suspicious when somebody comes in and just has ADHD. I rarely see those people. Usually I see those people when the family recognizes early enough and there's prior diagnosed sibling, and now we're getting in the younger sibling who's done really well because they were in sports 7 days a week, and now all they have is just the ADHD. But most of the time there's other issues that are happening, and other issues are anxiety disorders, mood disorders, bipolar, depression, PTSD, eating disorders are common, substance use is common. So there's usually other things that exist with ADHD. ADHD does not like to live alone, okay? I'm very suspicious when ADHD likes to live alone because I feel like we might be missing something, or luckily we picked up early enough that nothing else developed along with it. The other thing I often emphasize is coping mechanisms and compensatory strategies. So this is where I ask, how do you manage this? How do you manage to pay your bills? How do you manage to make it to your appointments? Oh, well, I have 5 calendars. Oh, well, I have everybody to remind me, right? So it's a compensatory strategy. If you didn't have that, how would you manage? Well, I have all automatic bill payments. That's why I pay on time, right? Well, the teacher always gave me extra time. So, you have to look at what compensatory strategies, and some people have come up with compensatory strategies because, they figured it out. People have helped them along the way. Sometimes the compensatory strategy is having a very good supportive friend group, whether it's in school or university, that kind of motivates you, keeps you responsible. And we often say, oh, well, they're not dysfunctional. Yeah, they're doing well because they came up with compensatory strategies. That doesn't mean they don't have ADHD. They do, and how else can we support despite the fact that, there's compensatory strategies? And, again, other sources of history is employment history. Are they losing jobs? Are they getting fired repeatedly? Are they struggling to keep a job? Are they missing appointments with you? Are they forgetting appointments? Are they constantly late? What's happening? What's the time management like? Because time management is a core issue in ADHD as well, whether it's running late, forgetting things, missing important things, forgetting their kid at school, missing classes, exams. So there's other things around that you could look that's going to give you objective evidence of impairment, even if the patient might not realize it's there. Next. Okay. So we do have to have this special consideration. We have to look at intergenerational component. So that's, I cannot emphasize enough of that because, you'll often have the adult patients who will probably recall some traumatizing experience with their parents and might identify that at least one of their parents likely had ADHD and struggled, whether it's gambling, addictions, anger outbursts, potentially chaotic eye bringing because the parents couldn't keep a job or pay bills or keep housing. And, and then when they have to parent now with their child, there's a huge issue with parenting, huge impact, the cognitive demand, the responsibility, the shame, they worry about their own child, how to advocate for the child in a system that might have lost them or dismissed them, right? So there's a ton of intergenerational stuff that's, really important for intervention to teach parenting skills, emotional regulation skills, as well as to deal with some shame and some trauma that might have been there. And it's very common. So I've done groups for moms with ADHD, and it's huge, huge, huge amount of shame, huge amount of guilt while they're trying to survive and manage. As I mentioned to geriatric population, that's a completely new thing. I don't know what to do about it. I get asked about that and I don't feel comfortable because it's very difficult for me to sometimes differentiate. Sometimes it's very clear, but many times it's very hard. So it's kind of a conundrum we need to learn more about. As anything, unfortunately, there is underdetection in BIPOC patients, immigrants, and low resource geographical areas. It's often when I see people from Northern Ontario, there was nobody mentioning anything or any supports provided despite the child clearly struggling. And it's just something that they do, or they drop out and nobody wonders why, right? Things about women, we have to really consider pregnancy, the impact of reproductive hormones. Women with ADHD have a 25% increased risk of developing postpartum depression, how to use stimulants in pregnancy, preconception. And women are often presenting with inattentive symptoms. So it's often missed because they're socially conditioned, they're compliant, they have good social skills, and they're often diagnosed with anxiety when it's actually overwhelmed because of cognitive demand. I did list some resources, particularly for women in pregnancy at the end, and a clinic at LHCC called Frame, where people can be referred if they want to talk about stimulants in pregnancy, risk and benefit. So that's something that's an extra resource I put in. The other thing we often miss is what's called high functioning, right? So these are people who are gifted, who have education, intelligent, and they might have achieved education, but they're struggling with everything else, with parenting, bills, taxes, maintaining a household. Or, they're struggling to complete their education. They're really smart and they have so much shame because there's such a discrepancy between what people think they should be doing to, taking 7 years to complete their undergrad degree, and they get suicidal, they can't cope, right? The other special consideration is how do we advocate for accommodations at work and school? And it is a human rights issue. ADHD is protected under human rights. We have to acknowledge that and help advocate for our patients to access the right accommodations. And, when we look at ADHD, it's very depressing when you look at all the deficits and everything that's wrong. So I really, really emphasize, more affirming approach. It's not a defect. It's a difference in how brain works, so that it's more about strength-based approach. We focus on the strengths while accommodating the deficit, okay? Because otherwise it's very difficult. It's very difficult to navigate the world knowing that your brain doesn't do basic things the way other people's brain does. And there's a lot of stigma, there's lots of shame, there's a lot of invalidation, there's a lot of joking. Even us starting the session by talking it's all over TikTok, that's a bit stigmatizing and reducing the severity of what people have to live with ADHD. So I always kind of emphasize, look, this is a difference. We need to learn, we need to accommodate, we need to address this, because we do have to focus on the strengths, because people with ADHD have tons of strengths, and yet the society shames for all the deficits because we see it as unprofessionalism, behavioral choices, personality issues, when it's literally their brain and the executive function that's not there the way other people have it. Next. All right. So that's kind of the emphasis. The big thing I would like to emphasize too is that ideally people with ADHD have a multidisciplinary treatment approach, because we need every team member. And I'll mention some of the roles in there. And the other thing that's happening with, one of my more recent literature reviews is that in my patients, I've seen a lot of medical comorbidities, a lot of diabetes, a lot of POTS, a lot of autoimmune conditions like lupus, and all sorts of stuff that often means more medical appointments, complex medication regimes. And I actually found an article most recently, I included it, that we actually do have evidence that people with ADHD are more likely to have endocrine conditions and all sorts of other complex medical conditions, which require doctor visits, which require usually multiple medications, and that affects the compliance, following up, because you missed one appointment, you're kind of lost to follow up. And you will see that in your patients. They have a higher burden of complex medical issues when they're already struggling to remember to take their medications and make appointments. So it's kind of not fair, because not only is their brain struggling already to manage all this stuff every day, now their body also has to manage more complex medical issues. So again, strength-based approach is what I advocate in any situation. Next. So this was a request from last year's group about, potentially where people can fit in roles, and kind of this is what I've put up from my experience. But, every one of you here is key part of your patient's treatment team. I wish if I won, giant $1 million lottery in the US, I wish we could have a publicly covered clinic where we would have everything together, including, family therapy and stuff like that. We're not there yet. But, with the social work, there's just so much that's so crucial for social work to provide and support, and therapy, parenting, legal and employment systems, right? So much, and parenting coaching, right? Occupational therapy, I'm sorry, I'm biased. They're my favorite group of people here. I know I've seen a few. I rely on occupational therapy absolutely for most of my patients. And, unfortunately, the ones who don't have coverage will not have access to that. But occupational therapists are huge, because they could do functional assessments, they could do therapy, they could have workplace, home, and school accommodations, they could do executive function coaching, skills coaching, and any tools. They are aware of any tools you could use to accommodate, whether it's apps, whether it's, at the last ADHD conference I went to, one of the OTs had a whole table of all sorts of accommodations, all sorts of tools she uses with her clients. It was amazing to see. Psychologist, of course, crucial for therapy, assessments. Psychiatrists, yes, we're important, we're in here. Family doctors are crucial, because the family doctor is usually the first person that they see. There's assessment, there's history. They usually know the whole family. They probably know the person for a while. The family doctor also manages their complex medical conditions when they miss that appointment with the specialist, and they have to re-refer or explain why the patients missed it. Case managers are also crucial, right? Because there's lots of supports, lots of resources, advocacy. Nursing, huge support. Pharmacist, absolutely, especially when I recommend blister packs. And of course, CYCs, child and youth workers, DSWs, huge, huge, huge supports in management therapy, navigating, especially in your transitions. So these are huge, huge supports. And hopefully this relates to some, and you guys, kind of add anything else that I could add for next year for crowdsourcing and kind of go from there. And so at this point, it's 2:45, so I'm gonna hand over the presentation in a few minutes, but just kind of leave it off, as again, I mentioned, I really think the strength-based approach, non-judgmental acceptance is huge for our clients because it's an invisible condition that's really tough and draining to live with every single day, that is still so misunderstood, that is judged, and literally every basic function could be affected, whether it's to take your medications, to pay your bills, to ensure housing, to keep a job, to keep a friendship, to, finish washing your dishes or laundry. It's a big condition. And the more we know, the more we work together, the more we can support people, the better it is for everybody involved.